Today we will discuss acute pericarditis starting from definition, acute inflammatory process affecting the pericardium which may coexist with myocarditis. Causes: infectious causes are viral, bacterial or tuberculosis. Inflammatory may be rheumatoid arthritis, systemic lupus erythematosus, rheumatic fever. Other causes are post-MI, uremia, malignancy and trauma. Types of pericarditis on the basis of etiology: acute is bacterial, chronic is tuberculosis, chronic recurring is viral, post-radiotherapy, post-surgical, drug-related like due to procainamide, hydralazine, penicillin, and bromelain, autoimmune due to the systemic lupus erythematosus, rheumatoid arthritis, uremic, idiopathic, malignant, or traumatic. Clinical features: the most important one is chest pain that is retrosternal, radiates to the shoulder and neck, aggravated by deep breathing, on moving, change of position, exercise, and swallowing. Low-grade fever, pericardial friction rub on auscultation is diagnostic of acute pericarditis that is high-pitched, superficial, scratching or crunching noise and heard incessantly. Investigations includes ECG showing ST elevation with upward concavity, PR interval depression, T wave inversion, echocardiography, chest X-ray showing cardiomegaly or increased cardiac cell counts. Management: the aim of management is to relieve the pain, subside the inflammation, and treat the underlying cause. Pain and inflammation is relieved by aspirin or endophthalmic. To rule out the underlying cause, we will do pericardiosynthesis. Type of pericardial effusion may be serous, showing the turbid, straw-colored fluid with raised protein content, or fibrinous that shows adhesion formations. Hemorrhagic is found in malignant, and purulent is found in sepsis, direct spread from intrathoracic infection, or any penetrating injury. According to the cause, the treatment is given like colchicine, glucocorticoids, antimicrobial. Dressel syndrome is associated with acute pericarditis due to the post-MI or autoimmune infections like SLE and rheumatoid arthritis. Signs and symptoms are pleurisy, fever, malaise, leukocytosis, and pericarditis. A scenario showing a 20-year-old boy who had fever, central dull chest pain that worsened on deep breathing and improved on leaning forward. There is progressive dyspnea, temperature, uh, tachycardia, blood pressure is raised, apic visa was not palpable, heart sound was soft and rough. Scratchy sound was audible all over the pericardium. Today we will study pericardial effusion, starting from definition. Abnormal accumulation of fluid in pericardium due to underlying inflammation of pericardium may be serous, fibrinous, hemorrhagic, or purulent. Causes: infectious number one cause is bacterial, streptococcus or Haemophilus. Viral causes are cytomegalovirus or Coxsackie virus, or tuberculosis. Inflammatory causes are rheumatoid arthritis, systemic lupus erythematosus, rheumatic fever, or polyarthritis nodosa. Other causes are uremia, post-MI, malignancy, and trauma. Clinical features is chest pain, dyspnea, cough, Kussmaul's sign that is ascension of neck veins on deep inspiration, fever, lightheadedness, oliguria, compression of adjacent structures that will lead to dysphagia, hoarseness, and hiccups. Investigations: general investigation, ask in history about post-MI, renal failure, tuberculosis, past medical surgical history. On inspection, you can appreciate sinuses and edema. On palpation, apical impulses are detectable, percussion note is dull, and auscultation, muffled heart sounds or frictional drop. Pulse will be compared with other lines. Blood pressure shows hypertension. They mirror the JVP. Pulsus paradoxus decrease in the blood pressure on inspiration, and respiratory rate is increased. ECG shows low voltage. Chest X-ray shows globular appearance that is increased signs of cardiac cell house. Echo is definitive, and pericardiosynthesis shows send fluid to rule out of. Diagnosis is based on PEG stride, 3Ds, decreased pulse pressure, decreased heart sounds, distended neck veins. Management: general management is symptomatic, manage the pain with the help of NSAIDs, decrease the inflammation with the help of NSAIDs and aspirin. Specific treatment is pericardiosynthesis, surgical drainage, and treat the underlying cause. Complications can develop like arrhythmia, bleeding, injury to the coronary artery, and cardiac tamponade. Scenario: a 38-year-old male, a couple of days of chest pain develops severe dyspnea and cough on deep inspiration, neck veins are distended, and ECG is low voltage. Thanks for watching. We will study cardiac tamponade, starting with definition. Acute heart failure due to compression of heart by large pericardial effusion. Clinical features: back stride, that is 3Ds, decreased pulse pressure, decreased heart sounds, distended neck veins. This is diagnostic criteria for cardiac tamponade. Other features are early third heart sound, dyspnea, collapse, pulsus paradoxus, Kussmaul's sign. Symptoms of acute heart failure are present if the person in cardiac tamponade presents with circulatory shock like tachycardia, collapse, hypotension, cold clammy skin, sweating, and sinuses. Investigations: ECG shows complexes are small and electrical alternates. Echocardiography shows diastolic collapse of right atrium and right ventricle. Chest X-ray shows enlarged globular heart. Management: cardiac tamponade is medical emergency. Percutaneous pericardiocentesis is done, surgical drainage of the fluid, and treat the underlying cause. Scenario: a 38-year-old man presents with chest pain, sweat, dyspnea, and cough. His temperature is raised, JVP is raised, ECG is low voltage. The diagnosis is. Today's topic is constrictive pericarditis. Chronic inflammation of pericardium resulting due to progressive thickening, calcification, and fibrosis, leading to obliteration or constriction of pericardium. Explanation: heart is encased in a solid shell and cannot fill properly. There is impaired myocardial contraction and breathlessness is not prominent. Causes are: the most common cause is tuberculosis. Second most common cause is idiopathic, hemopericardium, post-viral or post-MI. Rheumatoid arthritis, prurient pericarditis, uremia, radiation therapy, post-cardiac surgery, or tumor invasion. Clinical features are all features that are signs and symptoms of systemic venous congestion like fatigue, rapid low volume pulse, raised JVP, pericardial knock, ascites, hepatomegaly, peripheral edema, unexplained heart failure, atrial fibrillation. Four signs of constrictive pericarditis are Kussmaul's sign, pericardial knock, pulsus paradoxus, and Frederick sign. They can help us to diagnose constrictive pericarditis in a patient with unexplained heart failure. Differential diagnosis can be congestive heart failure, cardiac tamponade, renal failure, portal hypertension, or restrictive cardiomyopathy. General investigations includes asking about TB, trauma, viral infection, or MI on history, and on inspection there is raised GVP and pericardial knock on auscultation. Non-invasive investigations: ECG will be low voltage, lateral chest X-ray shows pericardial calcifications, echo shows diagnostic for constrictive heart failure, CT scan shows pericardial calcifications, and cardiac MRI is better than CT scan because MRI is good for soft tissues. Invasive investigations: cardiac catheterization and echo Doppler studies to distinguish it from restrictive cardiomyopathy, and pericardiocentesis to identify the cause. Treatment: general treatment is reassurance, dietary counseling for heart failure, fluid and electrolyte replacement. Medical treatment includes two diuretics like furosemide, aldosterone antagonists like spironolactone, and treat the underlying cause. Surgical treatment is pericardiocentesis and surgical resection of diseased pericardium like pericardiotectomy. Scenario: a patient presented with a slow onset of progressive dyspnea, fatigue, weakness, hepatomegaly, ascites, edema, and a small heart.